Dr. Wheless, he's a professor and chief of pediatric neurology at Tennessee Health Science Center. He's also the director of Bonheur Children's Hospital Neuroscience Institute and Comprehensive Epilepsy Program. He's certified in the American Board of Psychiatry, Neurology, specializes in epilepsy, tuberous sclerosis complex, Dravet, and he's also on multiple boards. Really looking forward to hearing his talk. And also Dr. Ketter, who's Chief of Pediatric Neurosciences at Helen DeVos Children's Hospital. He's trained in neurology in England and then did 2 years of fellowship training in epilepsy and neurophysiology at Harvard. He's done an additional year of advanced fellowship in epilepsy surgery, stereo EEG at Cleveland Clinic. And then before joining Helen DeVos, he was the director of stereo EEG program at the University of Pennsylvania, and then later the director of the Epilepsy Center at Children's Healthcare of Atlanta. And his clinical and research focus is mainly epilepsy surgery, intracranial EEG monitoring, brain mapping, cognitive neuroscience. So these speakers really know what they're talking about when we're talking about how to get these patients through this sometimes tortuous process. So really looking forward to their talks, and I believe, Dr. Wheless, you are up first. Please.
Thanks, Cliff. Good to be here. Let's see if I can. There we go. All right, so I have to remind you, for some of the folks in the audience, why do we even need this talk? And the answer is because when I started in this business, we had only 4 medications to treat epilepsy. So you really didn't need this talk because you could cycle through those pretty quickly and figure out if your patient, if the medicines were going to work or not going to work. In the modern era, we have over 30 medicines. So if I even do each one for 5 or 6 months, then I don't have to worry about ever pediatrics, figuring out if my patient's drug resistant because they're no longer a pediatric patient, they're in the adult clinic. So it becomes irrelevant. So that's really kind of how we got to where we are with this concept. It really wasn't until the late 70s and early 80s, and when I was in my training, carbamazepine and valproate were the new drugs on the block, and it wasn't even with those. It was as we started to get to the modern era of new drugs that we had to think about, like, well, wait a minute, how many of these are we actually going to cycle through, and what are we going to do with this? So the real question is, obviously, why do we need to know this? And the rest of this conference is going to be about, kind of the implications if you fail and you do have drug-resistant epilepsy. Oops, we went to disclosures next. Okay, I didn't realize those were going to pop up there. I don't think I have any disclosures related to this topic. I have a lot of disclosures. If there's ones that are not on here that you know about, please see me afterwards. I'd love to work with them as well. So I'm not opposed to that. But none of them are going to relate to what we're going to chat about today as well. So intractable epilepsy is not good, right? It's a miserable thing to have. Epilepsy is bad enough. If you're intractable, it's horrible. If you're the patient, for the folks we take care of, it's also horrible if you happen to have that patient in your family, because it impacts the whole family quality of life as well. I mean, we have a lot of families that have never been on vacation because their child had epilepsy. When I was camp director for one of the epilepsy camps here in Texas, we had families that was the first time they'd ever been separated from their child who was then a teenager because of their epilepsy. So we focused a lot on the kid, but obviously they don't live in isolation. We know that, those of us that do pediatrics and the whole slew of problems that occur with intractable epilepsy, which we're trying to prevent. So how did we get to our current definition then? Because as I said, when I started my training, we didn't have to worry about definition. There was no such thing as well. So because of the kind of the boom and kind of, oops, I've lost my ability to go forward here. There we go. In new drug development, at the end of the 80s, and the conference was held in the late 80s, there was a conference held on what is now no longer the FDA campus. It was a joint NIH, FDA, and thought leaders in epilepsy that I had a chance to attend. That was held in the old FDA campus. If you're interested, the new campus is in Rockville. It's the old Navy Ordnance Factory where in World War II, they made ordnances, so it's kind of cool to see that old building still intact as well. But the whole gist of the meeting was we had all these new drugs in the pipeline, and how do we figure out when epilepsy is refractory, because that was who was going to get the new drugs, and then even how do we make decisions beyond drugs. And at that point, yes, epilepsy surgery was around, but clearly underutilized compared to today's underutilization, even more so as well. So this was at the end of the Congress. You know, it's the usual. We spent a day and a half, the NIH and FDA, and we came up with this genius statement after a day and a half and, 40 some odd folks there, that if you couldn't get them under the control with either a primary care doctor or neurologist, and the best guess were 30% of patients. That was a guess. What's interesting is over time, that's turned out to be amazingly accurate. So one of the many things you learn is that, if you get enough experts together, their opinion is often not that far off of when you do real studies, the factual data as well, if you get your right experts. So was that kind of, now we go forward, how do we get to our modern definition? Credit, Martin Brody, and if you haven't been to Glasgow and to Western Infirmary, you should visit sometime. It's interesting. It's, been around since the late 1800s, the building they're in, a lot of history as well. But Martin is a family practitioner by training. Not even a neurologist, just happened to have an interest in epilepsy and adults with epilepsy. So he started doing, a very logical thing. He started just tracking all the new patients he was seeing. And as they put them on therapy, were they seizure-free, not seizure-free, response to treatment over time. And that's what kind of led to this, now famous New England Journal of Medicine pie chart that probably you could all draw in your sleep that kind of looked at, wow, if you pick the right medicines, if you don't get there with the first or second medicine, you really fall off. And because of our boon in multiple medications is why this was helpful to try and figure out when do we start to look at other therapies and where do we kind of put them in that sequence as well. If we go forward, there's multiple publications that have come out of Glasgow as we move forward in time, and newer anti-seizure medications were introduced to say, is it any better? Is it any different? If you look at one of their more recent publications that goes up to the modern era, you can see even with the patient numbers dramatically increased that they really didn't change a whole lot. And it still fits with now what we've all come to learn is the ILE definition. And if you like historical introduction of drugs, this is the other way you can look at it. The one that I've highlighted here that's still a bit of an unknown is cenobamate. This seems to be uniquely different as far as seizure-free rates from any medication we've had. If that continues to hold up, at least on the adult side where they've had the drug officially approved for several years, many adult centers are saying if we have a non-lesional refractory adult, we're not taking them to evaluation until they fail cenobamate because it's so distinctly more efficacious than the other drugs we've had. So this may be the one outlier here, but short of that, you can see over the decades kind of really not dramatic changes in seizure freedom rate. So the challenge that I have with this is I talk to a lot of my pediatric colleagues and they say, oh yes, we talk to our families about once you've been past 2 drugs, there's no point. And I have to stop and remind them that, wait a minute, that has nothing to do with what I do every day. 0. And they go, well, wait a minute, what are you talking about? That's like the dogma. Okay, well, this is why most people don't realize. So Martin made it very clear the patients had to be compliant to be counted. So think of your patients that come back and go, oh yeah, well, we kind of missed some medicine. They went to, dad's over the weekend. He doesn't give the medicine. The mom does. Okay, they were automatically thrown out. So that's not here, all right? If they had a surgically remedial lesion, and he had MRI during this whole time course, and it got better, obviously, as we got into the 90s and 2000s, 3 Tesla MRI. I mean, this is the major center in all of Scotland. It's not like this is out in the middle of nowhere with poor imaging. They went to the surgeon immediately. So they weren't like, oh, they failed 2 drugs and then went to the surgeon. He said, no, you're just going to go to the surgeon. You have a lesion. So those aren't in here as well, right? These were adults with partial seizures. So nothing to do with pediatrics, okay? So keep that in mind. If you're seeing adults, this is great because adults, 75% of their world is partial seizures. Little to do with what I do every day as well. All right, but this is what led to the ILE definition, and if you actually read the report they did, it says it's based on adults with refractory partial epilepsy. So what do we know about kids? So we have great pediatric data in kids. And so the Dutch have great, this is the advantage of socialized medicine, right? You can track everybody. Small country, only a couple epilepsy centers, so you don't have to worry about like they didn't like you, they went to another center. There's no other center. So you can track their data. They did a 5-year follow-up and a 15-year follow-up after diagnosis. They categorized all these children based on epilepsy seizure type and syndrome, so they could look at syndromic diagnosis and how do you do as far as seizure freedom. So you get this huge table where electroclinical syndrome was the key factor for refractoriness. And if you peel out of that, like partial seizures, for example, Quan and Brody, not a big surprise. Benign childhood epilepsy, now we call it self-limited, but same entity, 0% intractable. So we're never going to refer them to surgery, right? If you have more kind of typical, now we call focal seizure with impaired awareness epilepsy, yeah, you'll have 10, 15% refractory in childhood. If we look at some of the generalized seizures, the Lennox-Gastaut, not a surprise, 80% refractory. So not shocking. So it really highlighted that if you're seeing kids, yes, you can't just give, a same number of you failed this many drugs to everybody. You have to break it down by electroclinical syndrome and where you go with that. Because of this, the ILE actually, end of last year, recently updated their thinking about refractory epilepsy. Well worth reading, but if you go to the bottom of that, some of the conclusions, they clearly spell out it doesn't address the complexity because they finally realize, like, oh, not everybody has partial epilepsy, isn't it? There are other seizure types out there. There's kids. There's other etiologies we didn't figure out. It's far more complex than that, and we've got to think about where we go with this. I'll give you an example, a trial that I'm involved in now. It's kids that have SCN2A, gain of function epilepsy. So historically, these were all Lennox-Gastaut kids before we had genetic testing. They would have shown up as refractory Lennox-Gastaut kids. That disease is 100% lethal. None of those kids ever survive to adulthood, 100%. So that's about as bad as you can get, right? But yet, it's genetically, an ASO may prevent that. So it's not even going to show up with any of this stuff. So we really have to think kind of electroclinical syndrome, and then we've got to get to etiology. So are there etiologies that help us, when we're seeing kids, predict this? And there are. So if we go back to several large series, the ILE Pediatric Epilepsy Surgery Task Force, I happen to be involved with. It's a great task force. Somebody asked earlier. This was a good one to join if you want to be an international one because we met in DeLong, France. So we met in southern France for our meetings. It was great. So pick ones that have a good location, Don't pick the ones that meet in Cleveland. No, sorry. Hopefully nobody's here from Cleveland. Pick good ones, all right? But all of these, what do they show? And our surgical colleagues know this, and Brody knew this, when he started back in the 80s. The number one factor for surgical success is if you have an MRI lesion. So again, if you go to underdeveloped countries, and we did this when I was in Houston, we worked with the folks in Costa Rica to set up their first epilepsy center. The surgeon there was easy. We said, do folks that make sense, do lesional folks. You can do limited resources, you'll have great outcomes. Don't worry about all the other folks. You have plenty of those folks to deal with just from the get-go as well. But this was the key. So we know lesions, and then what about pediatrics? So what's our most common lesion for surgery? Focal cortical dysplasia. So we now have really good data for focal cortical dysplasias out of our colleagues in National Children's in Washington, where they've tracked these kids. And actually, if you have that on imaging and you aren't seizure-free with your first medicine, 90% chance you're not going to be seizure-free. So literally after one medicine, you should be talking about surgery to those folks, okay? So you should move on quickly. This is an old study that Dennis Dlugos did now decades ago out of CHOP. We looked at kids that came in clear temporal lobe epilepsy based on semiology and interictal EEG and showed that, again, after one medicine, if you weren't seizure-free, 90% predictant of who would become seizure-free or not. So it didn't take a long time to figure this out. So again, syndrome etiology. This is a more provocative recent article that looks at okay, do you even need to, get through multiple medicines? If you're not seizure-free on one, could you move on? And you see the huge kind of list here with them. I like the first one because I often hear this tossed about. People go, oh, they don't even take their medicines regularly. Why are we thinking about surgery? In my mind, that's like, wow, that's who you should be thinking about surgery because you no longer have to be adherent, right? Just show up for the surgery. And if we can fix you, great. Then you're done. I don't have to worry about it. I'm not going to probably fix your adherence, if you've had an established track record for that. But you see a lot of these lesions that we can tell our families, these are lesions that tend to do well. Lennox-Gastaut got brought up earlier. We're probably not going to make anybody with Lennox-Gastaut seizure-free, but if we can improve their quality of life with palliative procedures, why are we waiting until they've been on 7, 8, 9, 10 medicines? We should be probably looking at that kind of early on. So let me just finish up with the case just to give you some food for thought. A recent patient that we saw, It's an adolescent male. Had migraines, otherwise healthy. But our surgeons, I have to just put that in because our surgeons love it because, you always ask about medicines. Oh, not any medicines. And then, you're approaching the OR. Well, I do take BC powder every day. It's like, oh, yeah, they love that, right, Rick? Nothing makes for like platelet adhesiveness as someone that's taking BC powder every day and has, a nice unsticky platelets. Anyhow, he came in. He just said he got these spells. His PCP actually told him in a checkup that he felt weird. His smell was off. He said, I never have any impairment. Nobody even noticed. It was just a by-the-way thing at the PCP visit. You can argue to his credit, one way or the other, because he's a totally intact adolescent. The PCP said, oh, maybe we should get imaging, which I thought was pretty impressive. They got imaging, and our images come with arrows just like Dave's, which is nice. As well, and showed this abnormality, and I'll show you just a couple different views of it that we felt was a low-grade lesion. Because he had not had any spells that anybody had noticed at school where he was impaired, he kind of mentioned this to PCP. He had never been on medicines. So he came in and we said, okay, we're pretty sure these are seizures, but hey, since we're one of those high-income countries that Rick talked about, we could document what these spells are. All right, and I don't know I can do it from here. From the back, can you click on, did you just click on? Yeah, you did, thank you. And can we get volume by chance?
I'm good.
Thank you.
So they're asking,
I'm very. That's the diagnosis. That's or I'm in the hospital. St. Jude and
anyhow, nicely answering all the questions, with respect to floor, ceiling, he's going on. He was really hung up on this, like, oh, these never cause really problem, right? As well. So that was his first event. This was, let's see, do I have the next video? There we go. Can you play that one? So you probably won't be able to tell a huge difference with this. So he hits the bulb there. He stops. He's just saying, I had one.
You're okay.
Just giving it a thumbs up. Okay. But now he stops. He's not responding to them anymore. Just kind of this relatively brief pause. He's a little confused. It's like they're asking the questions. He's not sure what to do. So clearly some degree of impairment hadn't been picked up. His EEG, just, you guys are probably guessing as a lesion, but just, hey, since I do EEG, it's like chat show EEG, right? There's his onset, but this is just linking you through, and it's a typical, bipolar chain, left over right central, left over right temporal. You can see at the bottom a nice kind of rhythmic delta activity through his temporal lobe primarily to the end. So relatively brief, event. So, from our standpoint, it's like, wow, you've got a lesion, you're a healthy adolescent, you do have some with impairment. Most of yours don't. We agree, because most of them did not have any impairment. But, you're going to need surgery at some point. This is as good a time as any. We think you should, move on and do it. So there are some, and he never was placed on a medicine. So there's some you can argue, like, okay, you should move to surgery much quicker, and you really need a magic number for somebody like him. So I'll just remind you, the whole course of the rest of this conference is going to be about this, but just because you're pharmacoresistant doesn't mean you're treatment resistant. Those are sometimes confused. And remember, for most patients, if you do successful epilepsy surgery, you convert drug-resistant epilepsy to responsive epilepsy. If you look at across the spectrum of pediatric epilepsies, obviously our hope is quote-unquote cure, but if you define cure as going out 5-10 years seizure-free and off medicine, probably 20-25%. So it's not to say that we don't cure, but many more. This is a good goal, is to get them to where the seizures are controlled with medicine, and hopefully it is less medicine, with a burden that has not significant side effects, fits into their lifestyle, and they can go on being the kid that they are supposed to be. Anyhow, thank you for your attention. Hopefully that's given you some food for thought, and I'm going to stop there.